Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Thanks for tuning in to today's episode on the Super High Yield Anesthesia. So we're going to continue our adventures with opioids. Yay! So basically this one is going to be the more practical uses of opioids as a clinician, as opposed to the nitty-gritty details of the mechanisms, pharmacokinetics of each of the opioids. So it should be a little bit easier to follow, I would say, and not as technical. But it could also get technical because we're going to do some math. And ironically, as an anesthesia resident, I am bad at math. But it's okay. We're all going to be able to do this by the end of this episode, and it's going to be great. Okay, so to give you an outline of today's episode, we're going to first talk about like the general guidelines on using opioids on inpatient kind of acute pain service. Then we're going to kind of go over how to calculate morphine equivalents. This is where the math part is going to come in. And basically, it's going to be useful to convert between different types of opioids. We're going to briefly talk about opioid rotation. And lastly, we're going to talk about opioid side effects and how to manage them. Okay, with all that said, let's go ahead and get started. To start off this episode, we're going to talk about the general guidelines on using opioids. So basically, when you're prescribing opioids, the goal is to achieve the maximum analgesia possible with as minimal side effects as you can. Technically speaking, opioids don't have a maximum dose, but it's limited by the side effects. So for example, if you give too much opioids, you can have respiratory depression. You can have hyperalgesia. They can cause oversedation. So you technically can give a lot of opioids. However, will they be alive enough to enjoy the analgesic effects? That's the thing that we're worried about. So yes, we wanted to maximize the pain relief while minimizing the side effects. Next point is you generally have to be careful with any sort of combined formularies. Although it's kind of convenient for the patients on an outpatient kind of thing to have the opioids combined with, say, Tylenol, so like Percocet, Norcos, that kind of thing. But when you're managing a patient during the inpatient side, this could come up to a few problems. So, for example, if you order Percocet, but also order like round-the-clock Tylenol, you can run into issues with acetaminophen toxicity. So that's something to keep in mind. In my preference, when I'm ordering anything for anyone that's inpatient, is I like to separate the two. So I have, say for example, I just do oxycodone or something like that, but I have round-the-clock Tylenol. So that way, you're able to maximize the Tylenol without any issues with toxicity by overdoing the Tylenol. Okay. So next is the side effect. One of the side effects is going to be constipation. As one of my attendings here told me, like opioids is basically a constipation medication, as in it causes constipation with a side effect of relieving pain. So basically, anyone that's receiving any sort of opioids should have a bowel regimen. Honestly, like you could technically place like Miralax or some other laxative like Senna or something like that as PRN. But a lot of times when you put it as a PRN, these medications aren't going to be given. And when I prescribe any opioids, like I generally schedule the bowel regimen just so they have something going, because basically when you're trying to stay ahead of the constipation, right? Because say, for example, a patient's been admitted for like 3 days and then they experience the constipation, and then you start the laxatives, but it does take another day or two for it to actually work. So again, that's why I like to schedule my laxatives when it comes to if I know that they're going to get opioids pretty frequently. Obviously, you don't have to be too aggressive, like you're causing them diarrhea, but just schedule something. At least that's my preference. Next point is to understand which opioids are unfavorable in terms of certain illnesses. So, for example, if a patient has ESRD or some sort of kidney failure, you want to avoid drugs like morphine and meperidine because they could accumulate metabolites. Next point is when you start any opioid, and this is specifically for any patients who are opioid naive, say, for example, a 20-year-old that's previously healthy gets in a car wreck and is admitted for orthopedic surgery, that kind of thing. You want to start at a low dose of a short-acting opioid, and then from there, you kind of titrate up. So that's why things like oxycodone is going to be very effective for these particular patients. So, and you basically step up the dosage and or the frequency in a logical stepwise manner. So for me, generally, I start at a lower dose, say, example, 5 milligrams, 10 milligrams for moderate severe pain, respectively, at Q4 hours to start. But if it seems like the patient requires additional, I would decrease decrease the frequency to 3 hours, and then that doesn't work. I go up the dosage while increasing the frequency, etc., etc. It's just so I am able to titrate that. But again, that's just how I do it. Next point is regarding naloxone. So sometimes when you're trying to reverse the side effects of opioids, for example, respiratory depression or sedation, you have to remember that you're also reversing the analgesia. So especially for chronic pain people, if you end up giving naloxone to them, it might be very difficult to control the pain again because you're kind of taking that away. And lastly, one thing to note is even though you can sedate the patient, it doesn't always take the pain away. So like giving benzos or antihistamines could cause this sedation, but it's not going to provide any sort of analgesia. So definitely keep these things in mind when you're preparing a pain regimen. Okay, so in this next part, we're going to talk about morphine equivalent. So basically, when you try to convert between different opioids, there's like a different ratios of what's called equianalgesic dosing. So a certain amount of, say, morphine is going to be the or more or less equivocal to a certain dosage of oxycodone and vice versa. So there's a very useful table that's in the show notes, or you can look it up yourself. But just look up opioid equianalgesic dosing. Then it should give you some high yield, like a table that shows you the equivalence of PO versus IV opioid versus like different types of opioids. So for the purposes of this episode, we're going to mainly kind of talk about morphine, oxycodone, and hydromorphone, mainly because that's kind of the stuff that is commonly seen. Actually, we'll talk about hydrocodone as well. Those are the most commonly seen opioids, and I just want to at least give you some numbers so that it's in the back of your mind and you're able to convert that. Okay. So first of all, let's talk about morphine. So there's, as we kind of discussed previously, there's like two or multiple ways you can give it, mainly PO and IV. So 30 milligrams of PO morphine is about 10 milligrams of IV morphine. So 30 milligrams PO, 10 milligrams IV. Okay. So that's the first important one to know. And next off is converting morphine to hydromorphone. which also has PO and IV formats. So 30 milligrams PO morphine is equals to 7.5 milligrams PO hydromorphone or dilaudid, and 10 milligrams of IV morphine is equals to 1.5 milligrams of IV hydromorphone or dilaudid. Okay, so that's the main ones that you probably have to convert here and there between like IV drugs. Regarding the PO only for formulants or the opioids, things like oxycodone and hydrocodone. Oxycodone and hydrocodone have are 20 milligrams PO, and that's the equianalgesic dosing for morphine is 30 milligrams, and the equianalgesic dosing for hydromorphone is 7.5 milligrams. Okay, hopefully that didn't confuse you too much. It probably did. My bad. But basically, I encourage you just to look it up or take a look at the show notes. And the main takeaway from this is that for these major opioids that you commonly see, you're able to convert them from one to another and to determine the morphine equivalents that a patient requires each day. So for example, if a patient has 20 milligrams of oxycodone a day, and you're just trying to convert that just to get an idea of how much morphine that is, you can use that ratio to convert to morphine equivalent. So 20 milligrams of oxycodone is going to be 30 milligrams of PO morphine. Okay, and the reason why we kind of converted to morphine equivalents is mainly it's like the gold standard. It's like the gold standard unit when comparing different opioids. And over time, for example, if you're managing pain for a patient that's in an inpatient unit, you can see if the patient's pain is getting well controlled, then you can see the morphine equivalents kind of decrease over time, or vice versa. If it's not well controlled, you can see it increase over time. So it's one of those things where it's a good gold standard, and also it can help you see trends in the patient's pain control. Okay, so that's the general idea behind that table, and we'll kind of go through the steps as well as give you an example. Again, it's kind of hard to describe it over an audio format, so I would highly recommend you to take a look at the show notes in case you are confused, which is highly probable, unfortunately. Okay, so regarding steps, the main three steps are one, to calculate the total daily opioid requirement. So, for example, we'll actually get to the examples later. So, one, calculate the total daily opioid requirement. Two, convert daily requirement of old opioid to the new opioid. And three, convert to hourly dose. So, let's go over an example. Say a patient is on morphine 5 milligrams IV 4 times a day, or QID, while inpatient, and the primary team asks you for conversion to a PO regimen, and they're okay with oxycodone. So we're going to convert IV morphine to PO oxycodone. So step one, calculate the total daily opioid requirement. So as we know, the patient is getting 5 milligrams IV 4 times a day. So that's going to be 20 milligrams IV of IV morphine the entire day. So that's the total daily opioid requirement. So next, we're going to convert the old opioid to the new one. And this is when we're going to bust out our handy-dandy opioid equianalgesic dosing table. So we're basically going to set up ratios, and then we're going to solve for X. So on the left side of the equation, we're going to have 10 milligrams IV morphine over 20 milligrams of PO oxycodone, because those that's the ratio, conversion ratio, right? And on the equal side, then we're going to set it equals to the amount, the total daily opioid requirement over X. And we're going to be solving for X. So 20 milligrams IV morphine over X. And that's going to be X is the milligrams in PO oxycodone. So when you arrange all that stuff together and you solve for X, it's equals to 40 milligrams PO oxycodone. If you need to, take some time, pause the audio and kind of go over it again, you can. So that's the answer. And then from there, you're not actually going to use the full dosing. You're going to reduce it by 25%, because even though these are equianalgesic dosing, the changing from opioid to opioid could be different for patient to patient. So again, we're going to reduce it by 25%, and that's going to give you 30 milligrams of PO oxycodone. And the last step is to convert it to an hourly dose. So for example, we'll give it every 4 hours, so about 6 times a day. And 30 milligrams PO oxycodone divided by 6 is equals to 5 milligrams PO oxycodone Q 4 hours. Okay, so again, throwing numbers out always confuses me, so I totally get it if you didn't understand anything I was talking about. But I'll give you I want you to understand the main overall goal. So basically, you find out how much opioid a patient is on in a 24-hour period, and then from there, you use the opioid equianalgesic dosing table to find out the ratios and find out how much the current daily dose of the current opioid is for the new opioid that you're trying to convert to. So for example, and that we kind of just talked about, how much the morphine the patient is already on, and you're going to convert using the ratios to find out how much oxycodone that you're trying to switch to. And then from there, reduce the calculated dose by 25%, and then divide it by how often you want to give it in a day. Okay, so again, hope you understand the overall picture, but I highly encourage you to take a look at the show notes and kind of digest it that way as well. And of course, try to practice yourself if you can. And then sometimes the primary team will ask you for discharge recommendations. Basically, what I do is pretty much the same thing. See how much opioids that the patient is getting during the admission. And then from there, you decrease the amount of the dosing for discharge, because in the hospital, you're being monitored and everything, so that's great. But when they go home, you don't have the luxury of having nursing staff to make sure the patient is still alive, right? So usually I find out how much they're on during the hospital stay and decrease that, and then tell the discharging team to only prescribe it for a short course. So especially if it's post-surgical, usually the peak of post-surgical pain is around 3 days. So then usually that's I would recommend for a short course of like 3 to 4 days. Because if you give too much, then we run into a possibility of abuse, or a patient possibly selling the opioids, which is kind of cynical to think about, which is unfortunate, but it's just something that we have to keep in mind. Okay, so that's opioid conversions. Okay, so the next thing we're going to talk about briefly is opioid rotation. So when you have a patient, say, for example, they have been on PO oxycodone for a long time, but you keep increasing the dose. It works for a while, but then it stops being effective. You increase the dose, and same thing, works for a little bit, but the pain is uncontrolled, even though the dosage that you're giving is actually pretty high. So what you can do is what's called opioid rotation. So basically, you literally just switch to a different opioid. So for example, in that case, you can do PO oxycodone, switching over to PO Dilaudid. And then you use the same concept, the same method that we discussed previously, and converting the opioid to the different dosage and a different opioid. Right. So other reasons why you would do an opioid rotation is the things like the side effects of the current opioid is intolerable. The drugs that you want to give are not available in a specific route. And again, the other one is the pain is uncontrollable despite the optimal dose. So again, that's pretty much you're just switching to a different one. You use the opioid conversion table to kind of figure out what the new dose is. And then you reduce that dose by 25 to 50% to account for incomplete cross tolerance. And I think I forgot to explain this earlier, but incomplete cross tolerance mainly means that there are differences in structure and action on the mu receptors for the different opioids, and it could be different from patient to patient as well. So then conversion, when you switch opioids, you usually kind of go low and then titrate up as needed. Okay, and the last thing we're going to talk about in terms of this episode is going to be management of opioid side effects. And the main ones that we're going to focus on are allergic reaction, delirium/confusion, constipation, nausea, vomiting, pruritus, myoclonic jerking, sedation, and respiratory depression. Okay? Regarding allergic reactions, true allergic reactions are actually relatively rare, but these can include things like rash, hives, difficulty breathing. But if they say something like, oh, I get itchy or I get antsy or something, that's usually not a true allergy. And that's something that will be listed in the chart. But when you do a pre-op evaluation, just make sure you kind of figure out what exactly the reaction is. Honestly, like I've had patients that has a reported allergy, like morphine allergy or allergy to morphine, and it says something like a rash or something like that. And then usually I kind of just switch to a different opioid. But I've actually never had any problems with that. Knock on wood. But yeah, so again, just kind of figure out if it's a true allergy, especially if it's like a anaphylactic kind of thing. And it's kind of interesting too, like because the different opioids have different chemical structures, and they can be kind of broken into like 3 types of chemical structures as a whole. So I'm going to butcher these names, but phenanthrene, phenylpiperidine, and diphenylheptane. So those are 3 main classes, and under phenanthrene, these ones are things like codeine, hydrocodone, hydromorphone, morphine, oxycodone, oxymorphone. So basically the major ones that you think of when you think of opioids is in the phenanthrene. In phenylpiperidine, it's fentanyl, meperidine, sufentanil. And under diphenylheptane, it's just methadone. So the reason why I bring this up is if say, for example, we have an allergic reaction to some sort of opioid, say morphine. So in the same family, there are the other types of opioids. So like hydromorphone. So okay, if you're able to avoid those, then you can switch to something else, say fentanyl, which is in a different family. So that's just something to keep in mind. But again, the most important part is to really elucidate from physical exam and history what that reaction is and what that allergy is. Okay, next, delirium, confusion, and hallucinations. The way you can treat this is basically give less of it. So you reduce the dosing, or another option is the opioid rotation, as we kind of discussed in the last section. But if it's really, really bad, despite taking away the opioid, switching to a new one, you can try different neuroleptics if agitation is present, especially if it's going to harm the patient or they are harm to the staff. Okay, and certain options can be like haloperidol and olanzapine. Next is constipation, and we kind of touched upon this earlier, but it's going to be like a very, very common thing for anyone that's on opioids. So as I discussed earlier, I generally start a bowel regimen. You schedule it versus a PRN as soon as any sort of opioid is prescribed. So Miralax or Senna or something, just do something. But yes, that is what I do. And another option, assuming that the patient is NPO and they don't have like some sort of bowel obstruction, you can use metoclopramide, 10 milligrams IV Q6 hours to kind of help with the moving the GI system forward. Next is nausea vomiting. And it could be helpful to schedule antiemetics for a few days and switch it to PRN, especially if it's really bad for the patient experiences really bad nausea and vomiting. And by far the most common thing I will give is Zofran or ondansetron. But remember that the nausea vomiting has different receptors, so then you can try to target them as well. So prochlorperazine or compazine, metoclopramide or Reglan, haloperidol or Haldol, and scopolamine patches. Next, pruritus. So this is particularly common if the patient is given systemic opioids like IV stuff. Generally, they'll kind of present also with rash, hives, that kind of thing as well. In the absence of any rashes or hives, you should, on your back of your mind, in terms of differentials, is that the pruritus is secondary to mu-related kind of side effects versus a histamine release. And if it's like a mu-related thing, especially if they received intrathecal opioids, you can treat with nalbuphine, 5 milligrams IV Q6 hours, or if anything, you switched to a different opioid. Next thing is myoclonic jerking. So I personally, I think I've had one patient that complain of it, but I totally did not like put two and two together until like after the patient was discharged. But basically that patient was saying, oh yeah, he's on these opioids because he was in a car accident, status post ORF, etc. But he says like during the night, he kind of just twitches a little bit, like just one twitch. And then it's enough that it's noticeable and that it's kind of scary. Like every few hours, he just twitches. So I didn't think about it, but like, oh yeah, that's probably the myoclonic jerking because he was on a pretty significant amount of opioids actually. But anyways, so that's the possible side effects of opioids. So a way to treat it is you can reduce the dosage of the opioid or rotate to a different one. You can give some more hydration to basically try to increase the clearance of the toxic metabolites. But if it's severe, you can, in terms of acute management, you can use benzodiazepines. So like lorazepam, clonazepam, sorry. And another thing is the muscle relaxant, so baclofen. Okay, next is sedation. So basically, stop. Don't stop. No more. No more opioids. No opioids for you. So hold any sedatives, any other anxiolytics because they're synergistic with opioids. You can hold the opioid or you can reduce the opioid. Those are the main things you can do to treat sedation. Okay, so the last thing we're going to talk about in terms of opioid side effects is going to be respiratory depression. So the first thing that you're going to do is hold the opioid. So especially if they're on any PCA or something, stop that. Provide supportive measures and consider giving some naloxone. So there's this table in the pain management thing in the manual by Dana-Farber Cancer Institute, Brigham and Women's Hospital, that kind of gives you an algorithm on deciding when or if not to give naloxone. So it gives you some decision-making steps. So the first one, obviously, is if you're evaluating the patient and there's two of the following that are present. One is respiratory rate less than 8, 2, a RASS score of -4 to -5, and 3, if O2 sat is less than 90%, or there's a greater than 5% change from baseline in patients with SATs that are generally lower. So, for example, COPD patients. So if you're not familiar with it, RASS is kind of like a sedation score. So -4 is deep sedation, which means no response to voice, but there's a movement to physical stimulation, and RASS of -5 is unarousable, so no response to a voice or physical stimulation. So again, going back to the initial thing, if there's two of the following, you're going to move on, or two of those things that you're going to move on to the next one. Basically turn off any opioids as we discussed, all PCAs, you can turn that off and consider activating a rapid response, just so you have a little bit extra hands on deck. Try to arouse the patient either verbally or using tactile stimulation. And if the patient responds to any of that, so any verbal or tactile stimulation, you kind of just monitor them for every 5 minutes for 30 minutes, just like watch them and see what happens. If the patient remains stable after you stop all the opioids, basically you kind of have to readjust the opioid regimen. But if the patient is not stable, you're going to basically provide ventilatory assistance with a back valve mask, and then give the dilute IV naloxone to kind of reverse it. And then obviously from there, you can redose the naloxone because it generally has a shorter half-life compared to other opioids. So then you're going to, if the patient keeps going back into non-responsive state, then you're going to have to continue to give the naloxone. So yeah, so that's the basic decision-making tree. But say, for example, you come in, a patient has respiratory rate less than 4 and has a RASS score of -4 or -5, you basically go straight to a stat anesthesia respiratory call because that's it's going to be an airway emergency, so the patient might just have to be intubated. Okay, so that is just about it for the major opioids and pain management. I hope you learned something from this episode, and I hope you got something out of the previous one as well. And sorry if I confused you with all the numbers for the conversion table. It's like, trust me, once you look at it, it will make more sense. Okay, so the fun fact I have for you today is also from crack.com, because I just basically got found a bunch from here, so I've been stockpiling it just for you. And this one is: horses can nap standing up thanks to their special tendons. Sleeping on the ground leaves the horse vulnerable. So with the help of a special system of tendons and ligaments that lock the major joints in its legs, the horse can sleep for short periods while standing. All right, so yeah, so that's pretty much it. If you can do me a favor, if you have the time, if you can rate this podcast on Spotify or whatever, leave a comment or reach out to me on the social media accounts, links in the description, mainly just so I can, hear how these podcasts are going. And, if there's any room for improvement, I would love to hear it. Or, just say hi. That's cool too, because sometimes I feel like I'm screaming out into the void. But it's so occasionally I do hear from you guys in person. Sometimes, like, I just randomly meet people who've listened to the podcast and they tell me how helpful these things have been. So as long as one of you guys are benefiting from this, I will continue this because this is my labor of love. All right, guys. In terms of credits, this show has written and produced by myself. The main sources for this episode are Benzen's Essentials of Pain Medicine 2017. This is the 4th edition, and today's episode is from chapters 42 and 43. Some of the things that we discussed were from the Dana-Farber Cancer Institute, Brigham Women's Hospital, Pain Management Tables and Guidelines Manual from 2017. And lastly, open anesthesia for the discussion on opioid rotation. All right, so that's, oh yeah, sorry. Ooh, I almost forgot. It's a opening music by Brian Teal. All right, that does it for this episode. I hope you guys have a great rest of your day. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.